Everyone, today we have our conference, and this conference is very important specifically for the developing nations. And I want to give special thanks to all of our speakers, including Transhumanist Party, how they're supporting World Talent Economy Forum from the beginning, and all of the individual speakers, Mr. Rob, Mr. David Smith, Honorable Chairman, Mr. Gannady, Mr. David Wood, Professor Edwards, and Mr. Elias as well. And I'm sure these sessions will be very, very informative and very effective for Asia Pacific. And our session regularly we are sharing with the government, with corporations, as well as academia, and we are getting a huge response from them. And especially in this December, we have our very interesting summit for AI integrations and the human resource development. Perhaps it's one of the largest summit will happen in Malaysia. And we are like continuously we are growing, we are collaborating with many different organizations, but especially I want to give thanks to our speakers, because they are the resources, how they support us last more than 300 episode. This is really, really helpful for our youth communities. Even though many university they are utilizing our content for case study, as well as for their PhD program, MBA program, not only in Asia Pacific, even in France and USA, especially in California. So I love to give special thanks to all of our speakers, and hopefully in the futures, your collaboration, your intellectual support will help us to grow effectively. Beside that, World Talent Economy Forum, we are developing content for educational purpose, because we believe that startup and startup ecosystem development is very important. We have our honorable speakers from around the world, especially Transhumanist Parties has many scientists. So we are actually advocating with modern science, engineering, and technology. And especially we are introducing our different topics and different agenda to the governments, that they can learn from the developed nations and they can apply whatever importance. So already for the healthcare industry, for human resource development, for smart city development, for solar energy development, many government already tie up with World Talent Economy Forum. So we love to get more contribution for our from our speakers, especially with their research, with their coaching, with their consulting. We are very much open, especially people from developing nations. They need more of your support, more of your guideline, more of your advocacy. Especially we do discuss on public health and futures and this kind of things. COVID-19 situations is the most challenging part. Even now, Malaysia is lockdowns and many country lockdown. Beside that, vaccine is a big issue. I'm sure Honorable Chairman, Mr. Gannady, and all of the honorable speakers will bring very interesting discussions for our developing nations community. So before that, just for 30 seconds, there is an introductory speech from Professor Fred Philip. He is from Tando. Tando also supporting World Talent Economy Forums. Even Professor David Smith, he is also fellow from Tando. I just want to introduce his things. Then, as a keynote speaker, I request our honorable chairman, Mr. Gannady. So, okay.
Thank you, Mr. Sharif, for inviting me to kick off this conference with some brief introductory remarks. I've spoken with your audiences before. It's good to be back with them and with you. In the discussion of healthcare and public health, it's good to keep one thing in mind. The countries that are happiest, most economically successful, are the countries with healthy and educated people. Healthy and educated people. This implies a number of things. First, a country should have affordable health care available to all. This is not.
Thank you. I think we can add his remarks after the show even. So I directly want to request our honorable chairman, Mr. Gannady, for his keynote speech.
Thank you, Sharif. As always, it is an honor to be speaking here at the World Talent Economy Forum. My name is Gennady Stolyarov II. I am the chairman of the United States Transhumanist Party, which seeks to put science, health, and technology at the forefront of American politics. And I believe there has been no time in history where this goal has been as relevant as it is during our present time, when the world is still struggling through a pandemic that has caused unprecedented and cataclysmic economic and societal disruptions. And as early as March 2020, the US Transhumanist Party members recognized that technology offers the only way out of the predicament that the world is currently mired in. And in March of 2020, the US Transhumanist Party members voted to adopt 21 platform sections on COVID-19 responses, which emphasize the role of technology in making effective treatments and vaccines for COVID-19 available and affordable for all, desirably free for all. Now, in the United States, we've had some setbacks. We've had some efforts that did not proceed as quickly as we would have liked. In fact, the Moderna vaccine against COVID-19 was developed over the course of a weekend in January of 2020. Essentially, once the genetic sequence of the novel coronavirus had been discovered, researchers were amazingly quick at developing a vaccine that worked. It was just as effective then as it is now. And yet it took about 16 months to reach the 50% vaccination threshold in the United States. And in the meantime, nearly 600,000 people had died up to that point. I believe the death toll officially in the US has exceeded 600,000 right now. And it's most likely even greater than that because some of the excess mortality, even though it hasn't been officially attributed to COVID-19, most likely was due to COVID-19. So in my view, the greatest public health problem today, especially in the so-called developed world, is institutional sluggishness characterized by excessive adherence to the so-called precautionary principle, the idea that for an active technological or medical intervention, unless one can foresee and prevent all of the possible downsides in advance, one shouldn't try it. The problem with the precautionary principle is that it has an implicit bias in favor of the status quo, and it does not subject the status quo to the same kind of rigorous scrutiny that it subjects any potential innovation to. The fact is, in all of human history, there has never been a vaccine whose mortality was even 2 orders of magnitude lower than the mortality from COVID-19. So pretty much any vaccine, according to a rational benefit cost comparison, should have been eligible for immediate approval to be used by willing volunteers. And what we've seen with the COVID-19 vaccines from Pfizer and Moderna, but also from AstraZeneca, from Johnson & Johnson, is that the mortality rate among the vaccinated cohort plummets relative to those who have not been vaccinated. In fact, one statement that I would like to put forward is this: if there were a measure that you could take to essentially end the pandemic for you personally, would you do it? And it so happens that there is a measure that people can take in countries where there is abundant vaccine supply. In the United States, unfortunately, the Food and Drug Administration, while it did accelerate its typical approval process, which takes over a decade, and while it did grant emergency use authorization to the Pfizer and Moderna vaccines and then to the Johnson & Johnson vaccine, it dallied because of politics, and in particular because of a gentleman by the name of Dr. Eric Topol, who he said he was concerned about the vaccine approvals being rushed through because of political pressure from the Trump administration prior to the election. But I really think what happened was the vaccine emergency use authorization was delayed because certain people in the academic establishment and in the political establishment did not want the vaccine approvals to be to Donald Trump's credit. I was not a supporter of Donald Trump, by the way, but I thought it was disgraceful how the pandemic was politicized and prolonged for several months because of these political considerations. So, in my view, the developing world can learn a lot from what happened in the United States. We do have more than 50% of the population vaccinated right now. I strongly encourage everyone to get vaccinated if you have the chance, unless a medical doctor has told you you have some sort of special condition that would not render it safe for you to be vaccinated. But in most cases, if you're a healthy member of the general population, these are some of the best, most effective vaccines ever created. And they have some great potential, not just for COVID-19, but for other diseases, including cancer. This messenger RNA vaccine technology has been in development prior to the pandemic. It's very easy to adapt to emerging strains of the novel coronavirus, and hopefully the vaccine manufacturers will have other versions of the vaccines coming out that will address sufficiently divergent mutant strains of the novel coronavirus. And moreover, I think it is essential for anybody who is willing to have access to those vaccines from whatever manufacturer. They're all remarkably effective. And I would include in that list the Sputnik V vaccine that was developed in Russia, or the Sinovac vaccine that was developed in China. Essentially, any of these vaccines is remarkably better than no vaccine at all. And I think in the developed countries, because we have reached a situation where many people who wanted a vaccine were able to get one, some exporting of vaccines to developing countries needs to take effect, because this pandemic does not respect borders, and a mutation of a virus can spread from one country to another. European countries and to some extent the United States are dealing with the Delta variant of the novel coronavirus right now, which caused a lot of devastation in India over the past few months. And I think this speaks to the imperative of international collaboration in spreading the vaccine and in spreading good, accurate information about COVID-19 vaccines and their effectiveness, and the fact that they are a wonder of modern science and modern technology. So the U.S. Transhumanist Party stands ready to advocate for accelerated vaccine approval and availability and distribution, and minimizing the barriers to access for people who wish to protect themselves against this deadly pandemic, and people who wish to take part in efforts to protect against death and disease in the future, because this technology has a lot of potential even after this pandemic is resolved. So thank you very much for the opportunity to speak today.
Thank you, Honorable Chairman. Anybody has any questions to Mr. Ganady from the panelist?
Other than to say his remarks are quite on the mark.
Okay. From my side, I have few questions I want to ask Mr. Ganady. Number one, vaccine is a very important thing right now to solve this COVID-19 situation, specifically developing nations. They are highly density populated country. What you give example as India, even in Bangladesh, Indonesia, they're highly density populated country. So even though one of the vaccine initiators, their name is Bongo Vax, they are trying to develop vaccine from Bangladesh, and anyway, so their problem is that the peer reviewed journals and the process, sometimes they feel a lot of challenges from inside government and from the pharmaceuticals industry. Even though fully, if they're dependent on the developed nations, it's quite difficult right now to manage vaccine, even for Malaysia, and even every country has challenges. So What is your advice for this kind of initiative? And beside that, as Transhumanist Party has many scientists, especially from healthcare and pharmaceuticals industry, how these developing nations corporation, even though many corporations they communicate with us, they want to collaborate with more developed nation scientists, even research centers, how they can do that and how they can develop inside their countries, especially for developing healthcare system.
Yes, I think in the quest to make vaccines readily available in developing countries, decentralized distribution will be the key. We have seen in the United States the bottlenecks caused by institutional sluggishness, particularly at the federal level, because the federal government essentially arrogated to itself the sole ability to distribute certain services in association with COVID-19. And this went back to the start of the pandemic, essentially in January and February of 2020, a lot of private labs were developing COVID-19 test kits, and they were essentially told by the FDA and the CMS, no, you may not use those. The federal government will develop its own official test kit, and that test kit ended up being defective. So by a few weeks, we lost the ability to actually track the progression of the epidemic in the United States. Had 1,000 flowers been allowed to bloom metaphorically, and many test kits from private entities been made available, we would have had a handle on how many people were infected with COVID-19 back in January and February, when we knew that the disease was circulating, but we didn't know where and how many people. It looks like Edward would like to add something to this.
No, I just want to confirm what Gennady said, because literally the last day of February in 2020, I was at the FDA headquarters here in Maryland talking to them about reform. And I had had reports that private labs had come up with these test kits, and that the FDA, they couldn't basically get them out because of FDA delays. And I literally brought this up with FDA officials on the last day of February of last year, and sort of urged them to do something about it. And they sort of hemmed and hawed, well, we have a process here and this sort of thing. And then, of course, about 2 weeks later, the whole pandemic crisis opened up in the United States. So again, I was literally talking to FDA, and Gennady is absolutely correct. I knew that firsthand.
Yes, indeed. And I would just add that I think for the developing world, allowing a network of private organizations, foundations, even individuals to enter the country and offer easy, free distribution of vaccines, that would be a highly practical move, because it's not that hard to inject a dose of a vaccine into a person once you have the vaccine supply. So I think it would be most reliable, actually, for Western governments to work with these private organizations. If those organizations need doses of the vaccines, those doses exist. They're sitting in warehouses in the United States. So give the doses to the private philanthropic organizations, have people from those organizations come abroad, set up distribution centers where large numbers of the population can readily access them, and start vaccinating people. Don't set up a cumbersome verification process. Just anyone who wants to can come in, get a vaccination. That's the ideal approach. But David, you also want to add something.
I wanted to pick up your point, a very important point, that many of the administrative parts of government, the bureaucracies, have been found wanting in this time of crisis. And I wonder if anybody on the panel has had a chance to read the recent book by Neil Ferguson. He's a prolific historian, now based in Stanford. His most recent book is Doom, The Politics of Disaster. And he is excoriating on these bureaucracies. He's no fan of big government, to be clear, but his main point is that the competence level has actually gone down. We've tolerated too much mediocrity. He's in favor of having appropriate levels of checks and balances, but he thinks that compared to what happened in previous pandemics, and he has a lot about the 1957 flu pandemic and the 1968 flu flu pandemic, he thinks government was much smaller then, but much more effective. And that what we've lost is the effectiveness. So he still believes there should be an FDA. He still believes there should be all these levels, but they need to be much more highly competent. And we got to push for competence as well as push for getting rid of barriers.
Yeah, David, I'll confirm I haven't read that book and I'm very interested in looking at it. But one of the things I know, because I've attended FDA conferences, is they often complain about the lack of expertise. And so while they have 15,000 employees at one location and so forth, a lot of them are in fact administrative rather than the people who actually can do the science. And so even the FDA recognizes that they don't have the level of expertise, or at least I should say the people who are not just bureaucrats holding down jobs. So I found that, firsthand here.
And sometimes the more people there are, it actually goes slower. There's this thing in the world of software called the mythical man month. You can't make a project go 9 times faster by applying 9 times as many people. It's like asking a woman to give birth in 9 months by sharing the job out between 9 mothers. It doesn't work. And so there is a drawback to the scale. There are so many different levels of government, and there is a reason to have local government and state level government and county level government and goodness knows what else, but it's just getting in each other's way, which is a reason why, although in principle, the US and the UK in principle, we had good preparedness. We were evaluated as having great preparedness. In reality, we couldn't deliver. Why? Because of lesser competence than needed, and because all the different parts of government got in each other's way, stood in each other's toes. And so I think there's certainly a reason to apply science and best practice to the structure of government as well as to the application of science.
Yes. Anything, Mr. Gennady, want to add as a final remarks?
Yes. Well, I do think that in many cases, when it comes to dealing with the pandemic, we do have the technical knowledge, we have the technology, the obstacles in the way are institutional, and David and Edward both spoke eloquently as to what some of those obstacles are. Essentially, there needs to be some significant introspection among the leaders of institutions and among the staff. They need to ask themselves, what do we really want? Do we want good outcomes, or do we want to just follow the process that has been set up because that's the process that has been set up? And I think that's the general unfortunate tendency in Western societies since about the 1970s, that process has come to predominate over outcome. And while Western societies are capable of tremendous innovation and have exhibited leaps forward in the past, unfortunately, this kind of institutional rigidity has set in, and it has hampered our response to the pandemic. I really believe that the many hundreds of thousands of people in the US and millions in total throughout the Western world did not have to die. And that is, I think, the unfortunate result of the institutions not having caught up with our technical abilities. But I really think the developing world could learn from these lessons and avoid some of the death tolls that we have experienced here by encouraging swifter, prompter, more effective, more flexible action. And that could be in part governmental. It should be in part driven by private initiative as well. But essentially, whatever works as quickly as possible to get this pandemic under control based on scientific principles, that is what should be pursued.
Thank you. Thank you. Now I request Professor Edward, and thank you for your continuous support for World Talent Economy Forum. Yes.
Okay. Yes. Well, the first thing I'll say is that my remarks and the lessons I hopefully will be able to communicate are going to be applied differently in different countries and indeed different regions. I realize Asian Pacific area is varied. There's some very advanced countries and areas, Taiwan, Singapore, and so forth. Malaysia, Kuala Lumpur is certainly a major urban and industrial center. Others, of course, are rural and not in very good shape. So my remarks, please, to the audience, you have to apply them regionally and in your countries appropriately. I want to make four major points. The first thing is that as we look at a healthcare system in the future, we have to realize the importance of having customers and entrepreneurial suppliers. The fact that I'm having a discussion with people 12,000 miles away, 12 hours away, is because we had over the last 3 or 4 decades, entrepreneurs like Steve Jobs, Bill Gates, and the like, basically coming up with new inventions, trying them out with audiences, trying to convince audiences or customers, you should buy this, you should buy that. That dynamic is what produced the information and communications revolution. Yes, there was research done in government labs and DARPA and so forth, and of course, obviously universities, but it was the entrepreneurs who basically operationalized these and commercialized them so that more people could have access. In 2007, no one had a smartphone. Today, 87% of American adults have a smartphone. Think of that dynamism when you think about how to reform a future healthcare system. The second point I want to make, and I think everyone on this call, especially Gennady, agree with this, is the importance of exponential technology. And instead of simply looking backwards and saying, how can we tinker with the current system, maybe make it more efficient, do some of the things that we were just discussing, let's take a look at the potential of exponential technology. A few points. For example, to sequence a human genome in 2001 cost about $100 million. And in shows, I always like to say that 6 miles from where I am is where Greg Venter has his laboratory in Rockville, Maryland, that sequenced the human genome. I'm quite proud of what someone in Rockville was able to do. But it went from $100 million, not counting capital costs, and government also had its own program, incidentally, that's another discussion, to $100 million 2001 to $10 million in 2007. Today, you can get it for under $1,000, $500. You can sequence your whole genome, which means that you can discover all of the propensities you might have for diseases, for Alzheimer's, for whatever it is. Remarkable. Second, we now have wearable technologies that are accelerating. In other words, my phone here already can take some of my vital statistics and vital signs. An Aura ring that you wear can monitor your sleep if you have sleep problems. But there are others. A Fitbit watch can monitor a lot of issues. What we're going to see in the future is wearable diagnostics, where your yearly visit to the doctor, you're not going to have one because you're going to be monitored in real time. And when you have that real-time monitoring of your vitals, your blood platelets, all of these kinds of things going into a database where an AI evaluates it and basically says, oh, it looks like this fellow, this individual, not 47% of this group or that group, but this individual, Ed Hudgens, because we can look at his genome, we can tell he's about to have a heart attack. So we better get a medic to his door before he even knows he has a problem. That's what the future looks like. And again, imagine what the potential of that sort of a future. But it gets even better. I might not even have to worry about that heart attack, because if you discover those potentials, take a look at what you've seen just in the last 3 or 4 months with the use of the CRISPR-Cas9 genetic editing tool. For example, one breakthrough recently was able to turn off in neurons the production of what's called tau protein. Why is that important? Because it's a clumping of tau protein in neurons that causes Alzheimer's. It's associated with Alzheimer's. We literally have a technology that scientists are playing around with now that can potentially turn off Alzheimer's. So if if an AI sees that sequencing my genome, Hudgens has a potential for Alzheimer's, you just go in and turn it off. And something that just came out recently is, I think in the last week, is genetically engineering DNA that you can put back into the body to essentially give you incredible protection against cancer, Alzheimer's, and the like. This is using a genetic editing tool to create a certain kind of DNA and put it into a patient. And that's just in the last month or two that this sort of breakthrough has come. Can you see what that means in the future? And I know we've done whole shows about this. So the third point I want to make is we have to have public policy changes to allow for the unleashing of these incredible breakthroughs, so that they're not just in a laboratory somewhere, but they're with all of us. They're with hundreds of millions, if not billions, of people. That's going to include reform of our certification system. The Food and Drug Administration was set up in this country in 1962. I know something about the British system, David, and some of the other systems. And while they've had reforms along the way, a lot of them simply aren't up to the job of certifying and approving products on a swift basis, as we discovered with COVID-19. I point out two examples. In April of 2019, the Food and Drug Administration in the United States put out a request for input on how to regulate artificial intelligence software as a medical device in the same category as heart valves. And you might say, well, what does artificial intelligence is in a medical device? Well, they have the authority to regulate medical devices and medications. And I guess it's not a medication, it must be a medical device. Now, they haven't done a bad job of that, but you can see where the problems come in, that they have regulations that were set up in 1962 and amended that just simply don't address the technologies I've just discussed. That's a problem. One of the things I have advocated, and this is, I think, a step in the right direction, is, for example, in 1992, when when something like 45,000 people were dying of AIDS in the United States a year, just if you want to talk about a catastrophe, the FDA was saying, well, it might take 2, 3, 4 years to get this one checked, this one checked. And the AIDS patients said, we don't have 2, 3, or 4 years. We need it now. So the FDA created, under pressure for Congress, a parallel track where a product that had been determined to be safe and it looked like it would be effective, it passed maybe a phase 2 trial, that sufferers could access it on this parallel track even while it was being tested in clinical trials. And 12,000 people during the 3 years it was being tested in clinical trials accessed it and probably had their lives saved. There are reforms right now before the U.S. Congress and other places to basically say, let's set up that kind of parallel track. That the good thing about it is that if you take a medication or treatment on the parallel track, your data, how it works, how the product works for you and treatment works for you with your privacy protected, goes into a database. So you have real-time information flowing in that's open to everyone, so researchers can look at it. Doctors and patients can look at it and say, well, Ed, it looks like you have this particular problem, but look, we see that the real world data coming in suggests that this might be good for you. So maybe you should access it as well. That's just one example of a reform, but we'd have to have a lot more reforms. We'd have to have a reform of our medical insurance system, both the private sector medical insurance systems in this country and the government sector of medical insurance. We have Medicaid and Medicare in this country. Some systems, by the way, of course, have the government pays for everything. And then we have a lot of hybrid systems out there. I think Israel is a hybrid system, right, where you have government-based, but you can still buy private insurance for certain reasons. But the point is, you really have to look at how to do major policy reforms to allow the unleashing of this incredible technology. And by the way, what this means, of course, is we go from being a sick care system, which is what we really have now, to a healthcare system that focuses on prevention, that focuses on educating the public that about what they can do to remain healthy. The fourth thing and final thing I'll mention is a change of mind and a change of attitude. That is, so many people simply think, well, I'm going to die and there's not a whole lot I can do. I don't have really an incentive to keep healthy. Once I get sick, then I can argue with the government or the insurance company or whoever about who pays the bill. That's not a very good attitude. What I want to see is people who love life so much, who see so much potential in their personal lives, that they say, wow, if I can get a system, if I can get some sort of a insurance system or whatever you want to call it, a healthcare system that will allow me to live and to flourish. And so if I'm 95 years old or if I'm 89 years old, like my two parents, I can still be going out and doing things and enjoying life. Wow. We have to raise consciousness about the possibility that this can happen if we recognize, number one, the importance of letting patients make more choices, Number two, the potential of exponential technology. Number three, the need for policy changes. And number four, that will to health, that will to be healthy and to prosper, to realize it's actually possible. It's not science fiction anymore. So those are my remarks. And thanks for the opportunity, Sharif. And
Thank you.
I invite any
Thank
of
you.
your listeners who want to contact me, please do.
Definitely. I'm sure the audience, those who are observing today's shows, I'm sure that our speakers definitely, if you have any problem, anything you want to ask, any point you want to discuss, I think they are very active in social media. Everybody can communicate with them. So anybody has any questions to Professor Edward, or any point anyone want to add? Professor David Smith or Mr. Rob? Yeah, Mr. David Wood, yes.
And as you talk about your access across a broader range of information sharing, one of the challenges is always how do you protect privacy in the United States? How does HIPAA handle, particularly since many of the states are implementing their own healthcare privacy laws? And so in the United States, we're getting a patchwork set of rules set up. You know, Texas, for example, just passed a law where a breach in Texas is now more than 5 records exposed. Very different than the federal standard. And what's your view of how the protection of the patient confidential information plays in this, particularly as we move to a developing world where it's going to be even more patchwork than we have here?
Yeah, no, that's a very important issue. I tend to be a federalist in the sense that I want to see certain government functions handled at the most local level possible. Because what's good for Los Angeles or New York City is not necessarily good for Des Moines or for Rapid City or for Carson City, if I can give another example. And so that's always been the American approach, and I think it's a good approach, and it decentralizes power, and it means that if you live in South Carolina and you really think the government of South Carolina is a bunch of idiots, you can move somewhere else. And if you same thing if you live in California or New York, those are the states where people are moving out now. But I think you also have to look at the fact that in the American Constitution, this is a lesson that the Asian Pacific countries can understand. We also have a commerce clause in our Constitution that basically says that interstate commerce should be open, meaning that Pennsylvania cannot set up tariffs to keep products from Maryland out, and so forth. So I think that this discussion can fall under the Commerce Clause. One of the problems with insurance, by the way, is that insurance is handled locally. So what the insurance I can access in the state of Maryland is different from the insurance I can access in other states. Businesses in Maryland might be required to provide all sorts of things by the government that is not the case elsewhere. So I'm for a much more open system. One of the reforms, by the way, that happened, or one of the reforms that's been happening recently, and COVID certainly pointed this out, was because we're having this discussion right now, and with COVID, of course, a lot of doctor's appointments became virtual. My wife had to have an important doctor appointment, and it was one that she didn't actually need the physical test at that particular time, so she just did it virtual last year. One of my daughters has had some issues, and she's been able to do it virtually. But there's been an issue in this country about, for example, well, is a doctor in Maryland able to offer services virtually to somebody in Virginia, and will the insurance company pay for it? And so these are very important issues. And again, you mentioned protecting privacy as well. That's certainly one of the issues. And with a database that I mentioned, that's going to be an important issue. Now, one thing I will say is that the Food and Drug Administration actually has set up some databases for monitoring, for example, post-market results of certain products. So the FDA is always updating labels. And the way they update labels is they look at real world data coming in and saying, oh, look, we have to mention this particular qualification, that we've discovered, even though the product has been on the market for some years. We know now that if you have diabetes and you have this and this and this, you've got to only take this dose. So they're always doing that. And of course, that means that they have to protect the data. There are two systems, actually. One they have now, they're developing for medical devices. So this is a very important issue, and I don't downplay it. And it's one of the challenges we're going to have to deal with.
You're mute, Sharif.
You're muted, Sharif.
Mr. David Wood, I think you want to add some point?
Well, I'm a fan of making regulatory systems better. I completely agree that in many ways they are failing. But I wonder if we can highlight some examples of good regulatory systems actually here and now in the world. It's all too easy to say, hey, we should lighten the regulatory systems. But if there are ineffective regulations, what happens is that bridges fall down, buildings fall down, as sadly has happened in Florida recently.
Right.
And people do fall foul of drugs that should not have been allowed out. So I wonder what examples can any of us point to? And I honestly don't know what the right answer to this is. Perhaps Taiwan, perhaps, well, I don't know. So, Edward, what's your favorite example of a successful, lightweight, but effective regulatory system?
Oh, gee. There's some basics, obviously, in most countries, for example, concerning building regulations. And you don't want to make them overly, strict, but you want to make sure the buildings don't fall down. By the way, it's interesting that the unfortunate tragedy in Florida, when I heard about it, I immediately said to my wife, I said, it's going to be groundwater and it's going to be something to do with the underlying water system, because I was looking at examples where there was fear that we were having seawater or sea level rise because of global warming. And I looked at three examples, one in particular that's right here in the Maryland area. We have a Chesapeake Bay. It's a beautiful bay, lots of fish and crabs and all sorts of delicious critters in there. And there was concern that it was rising. And they did a study, and in fact, I edited the study myself. And what they found was, no, the sea level wasn't rising. What was happening was they were pumping too much groundwater out of some stations in Virginia, which is right over the border from Maryland. And so what it was causing the land to go down rather than the sea to go up. You had the same situation, by the way, in Houston and in, I think it was Santa Clara, California. So looking at these things are very interesting. By the way, one example I often like to give is that we have a system in the United States of private laboratories that certify, Underwriters Lab, for example, that certifies consumer products for safety, where they do the test, and you can be required, to example, to do a test, but you can choose a private lab to do it. Switzerland, I think, has that sort of a system, by the way, for their drug approval system, where you have to have approval. You don't want to have poison out there, but they have private laboratories, and what happens is the sponsor of the medication or the treatment can choose which laboratory. The laboratories have to be certified by the government. Okay, so you can't just set up your own laboratory in a garage or something and do it that way. So that would be an example where you have competition, but you have basic standards that, and of course, the only way these labs will be able to make any money is if they are very, very honest. If it comes out that, oh, they certified a product and they faked the evidence and the like, well, no one's going to go to them anymore. They'll probably end up being decertified to begin with. So those are a few examples of how you can kind of have minimalism, but you still have some standards, and competition helps out, I think. But again, it's a very important question, because I don't want my kids or myself to have bad medicine, or I don't want our buildings to fall down either.
And I would add, I do think there's an important role for regulation and protecting consumers against frauds and scams and product adulteration. And that was the original role of the Food and Drug Administration when it was established. There hadn't been that many effective medicines in the United States. The first effective artificially manufactured medicine was Bayer aspirin in 1910. And prior to that, in the 19th century, there were a lot of these so-called patent medicine scams where various often toxic substances were sold as cure-alls by traveling salespeople, and the FDA did do a good job in curtailing that. However, the problems really came into effect with the 1962 Kefauver-Harris amendments to the authority of the FDA, which turned it from a watchdog that protected against frauds and scams into this entity that had the complete power of prior approval or disapproval over all new drugs and medical devices that were introduced in the US.
Mm-hmm. Good points.
Mm-hmm. Thank you. Thank you. Thank you. Thank you, sir. Thank you, Professor Edwards. Now I request
I have to leave now, but I will certainly listen to the rest of the show when it's posted. So, gentlemen, I'm sorry I can't be with you, but I'm sure you'll be making very good remarks as you always do. So, bye-bye.
Thank you. Thank you. Thank you. Bye-bye. Take care. Bye. Yes. Yes, Mr. Ilyas Tambler. Do you want to give any presentation? Or?
Yes, thank you. I will try to share my screen. I hope I succeed. Share screen. No. Do you see my screen shared or no?
No.
Share.
Just from the share screen.
Okay.
Yes, I think.
Still not very. Do you see it now? The presentation?
Yes.
No?
Yes.
Fantastic. It's interesting. The systems are built. I cannot see myself anymore, but as long as you see my presentation, that's fine. Okay. Yeah, I can start.
Yes.
Thank you once again for the invitation. It is a pleasure to be here, and I will speak about promoting healthy longevity, which is obviously a very important topic for global health, for global healthcare, as well as for global economy, for the future of global health and global economy. I'm Ilyas Tambler. I'm chairman of an Israeli association called WTEF, the Movement for Longevity and Quality of Life, and I'm also active in other longevity advocacy organizations like International Longevity Alliance, International Society on Aging and Disease. So our main goal is to promote health and longevity through advancing research, development, and education. What are we talking about when we speak about health and longevity promotion? Basically, or mainly, we speak about intervention into the aging process. Obviously, aging is the phenomenon that shortens our lives the most and brings the most diseases. So the main point of longevity promotion of geroscience as a field is to say that by intervention into the processes of aging, we will be able to postpone or prevent multiple age-related diseases, and in this way extend health and longevity for the population. It sounds simple and trivial, but it's really a kind of a new paradigm that's been advanced by the geroscience. It is by no means entered the mainstream, though the importance and the validity of this approach should be obvious to everybody, especially during this pandemic, during this crisis. Clearly, COVID-19 affects mostly the older people and those people who are affected by multimorbidity. So a reasonable idea was that by intervention into aging or encouraging research into aging interventions, we will be able to prevent the main risk factors, the main causes of death and mortality, also in the COVID-19 patients. So that was the basic assumptions. I personally spent most of the last year promoting and advocating for this approach, for educating about the connection between the aging and immunity. We organized the international conferences online about this, started petitions, wrote scientific papers, also position papers with some of the leading figures in the neuroscience field, like Professor Barzilai and Professor Sierra and others, published in mainstream media. So the hope was that people will catch on this approach, that by intervention to aging will be able to also help mitigate the COVID-19 crisis. Forget all the other diseases that still plague us, like Alzheimer's and diabetes and heart disease and cancer, that are still having about the same death rates, and that could all be prevented by aging intervention. But now the world is focusing on COVID-19. So we thought that this approach would also help us cope with COVID-19. Unfortunately, after a year and a half of this advocacy, I can say that it didn't happen. This approach wasn't accepted widely by the general public or by decision makers. People mostly focusing on vaccines and the reactive approaches when the situation is already severe, not on the prevention or the general improvement of immunity of all the persons. Uh, so we can say that this approach was successful so far in terms of advocacy, but we'll build on it. At least there is now a great awareness about the vulnerability of all the persons. So I hope we will continue advocating for neuroscience, also when this crisis subsides, and we were left back with the usual all the old age related disease like Alzheimer's and heart disease and others. By the way, here in Israel, after the massive vaccination, the death rates is about exactly the same as it was in April last year and the April the year before, which means that other age-related diseases still taking the massive toll. Still, 60 million people die every year from those diseases. So we should also focus on them and advance research against those diseases as well, in addition to COVID-19. It is absolutely feasible. There are many proofs of feasibility that it is possible to intervene into aging and in this way extend health longevity. There are several classifications of the main aging processes, for example, the pillars of aging, or the hallmarks of aging, or the main the so-called seven deadly things in the sense approach, strategies for engineered negligible senescence. And the idea is the same, is that by intervention to this specific aging processes, we will be able to prevent multiple age-related disease and extend health longevity. What are actually sources of optimism? Why do we think that this is a feasible approach? Why do we believe that this is the future of medicine, as well as the future of health economy? There are quite a few. First of all, the life expectancy has been increasing for the past 100 years. Now it's subsiding in some places. For example, in the US and in UK, the life expectancy generally has been stalling or been going down for the last 3 years at least. So it shows that life expectancy is not, it's not written in stone. It's not the law of nature that will be increasing. It's mainly in our hands, in the hands of the healthcare system. But generally, life extension is pliable. We can affect it both for good and bad. There are many examples of organisms who do not age, so which shows that there's no law in nature that dictates that we all must age and die from all the age-related diseases. Of course, we develop in a certain environment. We do have a maximum lifespan, but there is no physical law that says that this lifespan cannot be increased. The technologies have been generally increasing, even accelerating, as has been noted earlier. There are many experimental studies that prove that it is possible to intervene into aging and extend the life. For example, in mice, it was possible to extend the life by 30%. Actually, from our university, a very recent study extended the lifespan of mice by about 25-30%. In simpler organisms, it is possible to extend the life by a factor of up to 10. So it shows that aging is not written in stone. It is possible to intervene and extend life as well as healthy life. Another source of activism is actually all this field is very young. The actual scientific, the first, I would say, scientific theory of aging was proposed in 1903 with the establishment of the field of gerontology in that year by Elie Mechnikov, a Russian-French biologist. So we see all this progress has been done in about 120 years. We still don't have many validated or any validated geroprotective or anti-aging treatments that we can say would for surely extend a healthy life, but the progress has been immense, at least in theory and in animal models. And we can compare it with the development of aviation. You know, also in 1903, the Wright brothers did the first flight, and we see where we're now. I believe if we invested as much effort and resources into the aging field, we would go even farther than with aviation. But now is the time to catch up and invest more. I know how much time I still have. There is a wide assortment of emerging geroprotective medications. Still, they're mostly shown as effective in animal models. So our goal is, as activists also is to advocate for more clinical trials, for more validation, and once again for more speedy regulatory approval for those medications who are found effective and safe. Of course, it is very important to understand that you cannot treat something that you cannot diagnose or cannot measure, especially for aging. In parallel with anti-aging medication, we also need to develop the biomarkers of aging, the clinical endpoints to show that these treatments are actually safe and effective. The branches of biomarkers and treatments go hand in hand, and they should be advanced together. So we do our part. As I mentioned last year, we published quite a lot about the connection of immunity and aging. Wouldn't say it made much of an impact compared to the vaccines, but you know, we try to make our contribution, at least to try to push for the more preventive approach. Now the emphasis on pathogens, we want to emphasize the terrain. If you look at the history of medicine, of immunology, there's this ongoing dispute between the proponents of the pathogen theory and the terrain theory about which side is important, your own body, the resilience of your own body, on the insults that attack it. Obviously, it's both, but you know, there's a different emphasis. Right now, the emphasis is on insults. We want to put a greater emphasis on the resilience on the terrain. And also in terms of measuring biomarkers of aging, we try to advance this agenda. We just completed a special issue, a special research topic in Frontiers in Genetics about the clinical evaluation criteria for aging and age-related multimorbidity. 9 articles were published presenting different approaches to the problem. And this is also important for the COVID-19 crisis. Obviously, if we are able to measure the health of all the people, we will also be able to ration or direct resources to the most vulnerable population to protect them. And still a very important part of this advocacy is education for health longevity. Nobody counseled the ages-old recipes of good sleep and exercise and good nutrition and will to life, life-affirming attitude. All this has been known for hundreds of years, maybe thousands of years, and it's still valid. Probably these are still the only means for health life extension that are proven to work, but still it does not contradict with the need to develop advanced science, advanced biomedical science. This should go hand in hand. And once again, as advocates, it is very important for us to explain to the society the need for such research, the need to invest in this research, the anti-aging research and neuroscience research for obvious economic reasons. Now we see, you know, once again, we have ourselves validated. A virus comes that some pathogen comes that mostly affects the elderly. And if they're frail, suddenly the economic system is collapsing and the healthcare system is collapsing. So once again, they should probably listened to us earlier when we asked for more investment in aging health. And we thought that now they do understand, but no, they still don't understand the importance of it. But we will keep on pushing. And this obviously concerns everybody: the general public, the pharmaceutical, medical technology industry, health insurance, regulators and policymakers, scientists and students. This is the real future of medicine and of health economy, as I believe, and as neuroscience advocates believe, because this is about prevention. This is about saving costs for the healthcare and welfare system. This is about the quality of life of every one of us and of our close ones. So this issue needs to be advocated as much as possible. And it's in any social cause, when we believe some issue needs to be promoted, we band together, we advocate, we create a movement. And exactly as with the green movement, or the movement for the rights of certain categories of the population, same for the health and longevity. We need to advocate. We need to actually educate the public and the decision makers. But we don't even have to wait for the general population, for the governments to take on this agenda. Every one of us can advance this agenda in his own life, in her own life, by getting together with like-minded people, by publicizing the recent scientific developments, by advocacy with the relevant structures. Every one of us has some access to some decision makers, and just leading healthy life, prolonging lifestyles, which will improve our chances to reach effective anti-aging and longevity promoting therapies when they arrive. I'll probably should stop very soon. Just some examples of our advocacy activities internationally. We have been organizing for about 10 years the so-called Longevity Month in October, where we raise awareness, encourage people to organize events to stimulate public discussion about longevity research and treatment. So hopefully also this year we will be able to organize some events and promotions in October. Internationally, I had the honor to be involved in some initiatives, like the campaign to include aging into the WHO work program, together with the International Longevity Alliance, with the International Society on Aging and Disease. Actually, thanks to this advocacy, the WHO included aging into its work program for the first time in history. Can you imagine? It wasn't on WHO agenda. Now they're still forgetting about it, still moving in the other directions. But it shows that thanks to advocacy, it is possible to change public health policy even at such a global level. And also important development from the International Longevity Alliance is the recognition of aging as a modifying factor in the international classification of disease. Once again, it shows that even with minimal funds, just with persistence and advocacy, it is possible to affect global policy for health and longevity. And here in Israel, we also try to advance as much as we can. We have very little support, but just from pure activism, from pure enthusiasm, we were able to introduce the topic of health and longevity research, development, and education into the Israel National Master Plan on Aging. As a result of our advocacy, there were issued several calls for research proposals to encourage the scientific involvement in the field. For example, the BioRx Aging Program, the Britain-Israel Research and Academic Exchange on Aging. We had the honor to write the first draft of this call for research proposals. 200 labs submitted, 100 from the UK, 100 from Israel. So this is a very successful model. If you ask for lessons for the developing countries, this is a very successful model, the model of collaboration. Just thanks to collaboration between different countries, it is possible to improve the scope and quality of research. So I hope there'll be more initiatives like that, and not just in the developed countries. We have to be honest. For the most part, this research has been done in the developed countries and Western countries, but we definitely need to spread the outreach also for the developing countries, for the low-income countries, because this affects everyone. A lot of talent is hidden and not accessed in those areas, so we really need to foster it and to help it develop this important field for all of us. Thank you.
Thank you. Thank you. Anyone want to add some point with Mr. Elias? Any speakers? Oh,
no, everybody agrees.
Okay, okay.
Well, I got here a little. Oops, I'm so sorry I was late. But did you talk about the different theories of aging? There are quite a few. I mean, we're really not sure at all what causes aging, right? There's the programmatic theories and the basically wear and tear types of theories.
Right.
Are you feeling that we're really honing in on some sort of a set of theories that we're really clear on what we can do or what's actually causing aging? I didn't think we even understood that yet.
Well, that's a part of developing the metrics of aging. That's a part of developing the diagnostic approaches. Right now, what we can do is to develop some operational approaches to measuring aging. Yes, in final labs, we do need the unifying theory of aging, but that can take a few decades. For what we can do now is define aging operationally and seek anti-aging treatments operationally, and that is very important. That can help our healthcare system in the shorter run. But for the future, it is a very fundamental process. What it means to age and how we can prevent it. Definitely, and that will be a topic for the next few decades or centuries.
Okay, great. Now I understand. Thank you.
I would add that I would
you.
encourage you to take a look at the website whose link I shared, SENS.org. SENS stands for Strategies for Engineered Negligible Senescence. It is a research foundation and an approach advocated by Dr. Aubrey de Grey, who essentially focuses on addressing aging-related damage from an engineering standpoint. And his main idea is that while it will take a long time to fully develop a theory of how all of the changes in metabolism contribute to aging, there is damage that we can fix because the damage manifests itself in 7 main types. And Ilya had a slide that showed the 7 types of age-related damage and possible treatments. So the idea is, while it may take us a while to reconfigure human biology to, for instance, slow down the aging process, what we can do is periodically, as the damage of aging accumulates, repair it and set back the biological clock. And then after that point in time, perhaps a 60-year-old can be transformed to the equivalent of today's biological 40-year-old. He or she will still keep aging as 40-year-olds do, but that person will now have 20 years of additional time in which even more effective treatments for rejuvenation and repair can be developed. So at the point at which we can periodically reset our biological ages, we will have bought ourselves a lot more time for the theory to advance and for this fundamental understanding to be reached.
That's great, and I really think we can all do that by having better diets and exercises and antioxidants. But one of the theories of aging, though, is that we evolved that would be bad for our species to have super long lifespans because we wouldn't be able to evolve, basically, and that it's built into our biological system that we age. So in some senses, it looks like we're going to have to get in and reprogram our DNA to basically behave differently. So that's independent of the damage that's done. There's actually it looks like there's kind of a clock in us that sets the sets the lifespan for us. So that's a different issue. It's really interesting. I posted the link.
Big issue. Listen, we could have a conference for 8 hours just talking about ethical implications. Happy to discuss, probably. Yeah.
This is not about ethical implications. This is about theories of aging.
No, it's theories of aging, yeah.
And I'm going to be a bit controversial here. I think the SENS Foundation website is remarkable. There is great information there. Aubrey is a talented communicator, but the best book on this, in my view, is a recent book by Andrew Steele on age. It's called Ageless. He's got a picture of a turtle on the front cover, and he looks at these different theories of aging. And I think he's marvelously clear as a communicator. And he looks at these theories that there might be a clock, there might be something that as individuals we suffer for the sake of our species, and I think he does an excellent job of saying there's nothing fundamental in any of these in our understanding of biology, which means we cannot address these issues. So rather than having an 8-hour-long discussion, which we can't because we're already way over schedule, I just point you at Andrew Steele's book. It's within the last year, and he also has great videos, by the way. His excellent communicator uses marvelous presentation techniques, so we can all learn from him, in my view.
Thank you.
It's also my it is also ethical, but you see that the moment theory of aging is raised, immediately we ask ourselves, should we intervene? What will it do for the society? It's a very complex knot of issues. Tangle of issues, so it will occupy us, I believe, for the next decades. But we have to start somewhere, and I believe we need to start with advocacy, with increasing investment in longevity research, development, and education.
Sounds great.
Yeah.
Thank you. Now I request our honorable speaker, Mr. Rob. He actually from day one, he also support World Talent Economy Forum. Thank you for all of your support. So, Mr. Rob.
Hi, good morning. Whenever trying to fix a process, in his background, I ran a Tiger team in IBM for a number of years. The team, our purpose was to go in and discover problems and mitigate them at an aggressive level. We had hiring and firing capability, and we often could place our members in to replace executives that were underperforming. What I learned was if you want to fix something, you need to know where you are and you need to know where you want to go. The problem we've got with the medical community is, in many cases, we don't know where we are. The databases that we have, and this came up during the COVID mitigation phase, they don't talk to each other. They have different formats, and they're surrounded by different layers of regulation. So if you want to do a study that cuts across the medical information of the world and thus develop things like vaccines very rapidly, you can't do it. At least not with the level of accuracy that could result from using these massive amounts of data, because we don't have access. The databases aren't compatible, and to make them so that you can read all the databases takes a considerable amount of time. And those problems haven't been fixed. It was one of the biggest frustrations of the data scientists that were doing the work is they could see the data, they knew where it existed. They either couldn't get access to it, or they couldn't quickly convert the databases into something that they could collectively analyze. Now, over time, some of that was mitigated, not all of it, and we haven't put in place any kind of a process long term to fix that. And the next pandemic might be even more deadly than the last. In fact, as we go through COVID variants, each variant has been more deadly to a large extent than the last. And so the D variant is the most deadly yet. And still, we don't have a worldwide response to it. We clearly had issues. A lot of the issues with regard to governments dealing with problems like this, they tend to deal with them tactically. So initially, the first phase should have been a heavy prevention. In other words, immediately move to masks, immediately move to social distancing, immediately restricting travel between states. Concern about economic impact delayed those moves. So then the states and countries had to start shutting down, which was even a greater economic impact than what would have happened had they just put in place mediation methods, prevention methods to keep the disease from spreading. And that shows the decision process is still tactical. And for medical types of emergencies, you need a strategic response. You need to respond in a way that's definitive and as quickly as possible, at least gives you the time to develop a vaccine and go forward. If you can implement rapidly programs that stop the vaccine from spreading, now you have plenty of time, or at least a lot more time, to develop a way to mitigate it, whether it's a medication like remdesivir, or if it's a vaccine like the ones we currently have in place. If you've got another year to do that, you can better assure the vaccine and better assure the confidence in the result. One of the big problems we've got right now is we didn't do the work with the populations to make them comfortable with the process. And particularly here in the United States, we have a critical mass of people that are refusing vaccines, who are undoubtedly going to be the cause of an eventual variant that bypasses the vaccines that we currently have. It's unfortunate, and we could stop it, but we're not going to do anything about this until it becomes a major problem, and then we'll respond to it tactically. That is not the way to respond to programs like this. I mentioned you need to know 2 points. You need to know where you are. That means you need to know what the status of your medical capabilities are now. And the issue with that is everybody wants to make their medical situation look like it's better than it is. Nobody wants to be blamed for a bad department, a bad division, a bad capability. And so governments have a tendency to cover up their problems. You can't fix anything if you're spending most of your effort covering up the issues that you've got. So step one is you have to be honest about where it is you are. Now, you also have to understand where it is you want to go. When I mentioned strategic response, we should be developing a process whereby we can mitigate viruses like this on a regular basis. We had SARS a decade ago. We had the opportunity to develop this process. We did not. There were attempts in the United States to do so. The last administration here pretty much tanked those attempts, and we ended up starting all over again. That can't happen. We need to develop a definitive way to respond to pandemics. We know they're going to come again. We know they're going to come on a cadence of between 5 and 10 years, and we need to be ready for the next one, but we're not. That means we really need to have a good idea of where we want to take the medical community. Probably more towards prevention than towards cure. The prevention is generally cheaper to implement. It does require social engineering, but that's really where the effort should be going in now, getting the population to do what it is you need them to do when you need to do it. When I was a kid, we had nuclear drills. I don't think they really did much good. I have this mental image of being able to, we called it duck and cover, and we crawled underneath our desks and turned our backs to the windows in case of nuclear attack. With the full realization now, we probably would have all died. But we were trained to do that as a group, and we did it young. So when they told us to do something, we did it. In response to any kind of a threat, whether it's a medical threat or a physical threat, you need the population ready to respond and make themselves safe. If you tell them to get to shelter, they have to go to shelter. If they don't go to shelter, you're spending a lot of your resources pulling them out of difficult situations that they otherwise wouldn't be in if they follow the advice of government. And that goes back to government needs to be transparent and trustworthy so people will trust it. And if we don't get to that particular point, we'll never get to the point where we can tell a population to do what we need them to do to mitigate a problem. And we are not anywhere near there yet. Now, finally, as we look at how the medical industry needs to be, it really needs to be much more focused on prevention than it currently is. And one of the big problems we've got is the economics are wrong. If you look at the economics of medical care, most of the money is made through mitigating an illness. In other words, if the flu money mostly goes towards flu medicine, which makes you feel better but doesn't cure you. It doesn't go towards the antiviral efforts. If you want to fix this, the economics of this have to be fixed. Prevention methods tend to go to different entities than mitigation efforts and cure. So your methods to keep people from getting sick might go to a health club. It might go to a physical therapist. Might simply go to practices in education. Those are not the same folks as Johnson & Johnson, who's making the stuff that makes you feel better, but doesn't necessarily cure you outside of the vaccine. So fixing the economics so that the money flows the way you want it to flow and people are encouraged to do the right thing is critical to make this better. As long as we incent mitigating illnesses as opposed to curing them, we're not going to cure a lot of illnesses. And finally, if we're going to make the populace well, we need a hierarchy. Where should the money go first? At the very least, we should have a ranking of what kills people, and then the funding should go against that ranking. What's killing the most people should get the most funding until that problem goes away. Then the next item down, we fund and fix, and then we make progress. The way we're doing it now, we're not making progress. The things that were killing us 10 years ago are killing us now. And there's no indication that that's ever going to change. Yes, we're investing in cancer research. We've been investing in cancer research for decades. I've lost, I think, 10 members of my family to cancer. Nothing much has really changed yet. The medications that we're using, largely a process of poisoning the body, was developed decades ago by a doctor that broke convention and decided to try something that if it hadn't worked, he would have lost his medical license. We don't get people like that often. And that the very concept of using poison to fix a disease is something that should have been tactical and short term, not something that's strategic and we do forever. Steve Jobs died because of his fear of that treatment. In the end, it's a case of moving forward, and you can't move forward if you don't have a goal. You can't move forward if you don't know where you are, and you can't move forward if you approach these problems tactically as opposed to strategically. So that's where we need to really rethink our entire approach to healthcare, make it rational, create goals that are achievable and solid, and be honest about where we are so we can get to where we want to go.
Thank you. Thank you. Anyone has any remarks or any questions to Mr. Rob?
Hey, David.
Rob, I thought that was really inspiring and refreshing. But I want to ask you, what is your suggestion how we actually do change the economic incentives? Because I accept, there is insufficient incentives for for companies to invest in developing vaccines. I mean, vaccines have been under-targeted in the past because they're very difficult and often they don't make money. So, and that's just one example. So what do you have in mind so we can preserve the best of what's good about the current free market economy, but steer it in ways that we have more focus on these other issues that you've identified?
Well, government has a couple tools in their a couple arrows in their quiver, and the most powerful are economic incentives. Government can incent the behavior they want, and they can tax the behavior that they don't want, and that can change the underlying behavior. We know fully well that taxes can change how companies behave. We've seen the impact it has on bad behavior with regard to global warming. If it's done properly, granted, we've seen some other things like carbon sharing and selling carbon futures that are a little bit more problematic. But if the tools are used properly, government has an economic tool that they can use to drive the proper behavior. They've got another tool they can use too, and that's education. Government has the ability to educate a population and underutilizes it. We get too much fake news. Like here in the U.S., it's out of control. But there's too much bad information now flowing through pretty much every country. During the war, we called it propaganda. Here, the sources are just as troubling. But at the very least, the government really needs to take control of its own image and its own capability. Yeah, I kind of get how that could be misused. But right now, we've got a much bigger problem, I think. And the fact is that if government's going to abuse their population, that's a very different problem we're not discussing today. But they have the tools. Not using the tools even to help us would be inappropriate. Suboptimal, maybe.
Thank you. Okay. Anyone want to add any points with Mr. Rob? Okay, thank you. Now I want to request Professor David Smith. He is also fellow from Tando. There's a global think tank. So Professor David Smith.
You're muted, David.
Okay.
Thank you so much for allowing me to be on this. This topic is one that's near and dear to me. Particularly since I was on some innovation committees with NHI and others on this area. I think one of the places really to go back and start this with is if you go way back to when the Institute of Medicine here in the United States defined public health. And it's what we as a society collectively do to ensure the conditions for people to be healthy. And to me, as you begin to use that as one of the definitions, it changes a little bit for me how we frame the problem, how we look at the problem with it. And you can break it easily into different segments. As I look at public health and the future of healthcare, I look at the sustainability of the healthcare system. Particularly with COVID, we see that the sustainability of healthcare systems in many instances was severely stretched and put to the test. And in many places, they stepped up. Many places, they failed as well. And, the sustainability of the healthcare system goes across the different approaches of how we approach public health, how we begin to do the elements of that. Here in the United States, if you look at what CMS has done, what Health and Human Services has done, what the Office of the National Coordinator for Health has done, one of the things they attempted to do a couple of years ago, and it's still ongoing, is they tried to change healthcare from something that when you're sick, let's come in and partially fix it. And the reason I say partially fix it is the incentive here was what's called fee for services. And doctors didn't get fees if you were all the way well. So healthcare had that. Where the United States is shifting now is something called more a value-based medicine or quality-based medicine, where physicians and others actually make more money by preventing disease, doing the tests and procedures to help prevent disease versus fixing you when you're sick. And if I'm looking at public health as a policy piece, this movement towards value-based medicine, quality-based medicine is one which I think has a lot of strength as I begin to globalize, particularly into developing countries, the approach to healthcare. It's taking a long time. There's doctors who resist it still here, but it's important because it's tied into the payment system of the largest healthcare payer in the United States, which is CMS, Medicaid, Medicare. And so it is picking up initiative that way. Another way as I look at public health is how do you begin to enable access to healthcare? And for many years, this was really lagging with what we had even in the United States. There was a tattered set of regulations, much like we talked earlier about patient privacy, even with access to telemed, access to being able to work across state lines. I got sick during one of my trips, actually from Texas to California, and it was a real pain trying to get my doctor to prescribe drugs for me in California because they were not registered to practice there. So you see that as you work through part of this. Healthcare has challenges with the different demographics. There's demographics who are not as involved in the process of healthcare, and it's harder to deal with it. Rural healthcare, no matter where you are in the world, is a challenge. Many of you who watched some of the prior versions of this with Sharif know that my company, Economic Transformation Technology, is doing work in developing nations a lot, because part of our strategy is not just commercial, but how to help emerging countries do better. And we're putting in wireless mesh internet access in rural countries using TV band space, because you can get big chunks of bandwidth that way. One of the prime applications on that is telehealth and beginning to pull it into that. And telehealth, different than we have here, In the United States, you have to have a relationship with a provider before you can do telemed with them. I think as we look at the rest of the world, being able to go to a nurse practitioner, going or to a physician assistant or other types like that, going into a mental health specialist will really help as we take public health and move it more globally, particularly in the rural environment where there's just not an incentive today to go and deliver quality healthcare in that rural environment. Another big area as I look at public health is the healthcare technology, which we've already spoken quite a bit about today. But we've talked about discrete devices, and if I go into an ambulatory surgical center today, most of them are connected wirelessly in most instances, many with Zigbee technology into the health systems there. Medical devices there, but the biggest approach is not only the consumer medical devices, like my watch that will tell me what my heart rate is right now, what my respiration rates, all that stuff, and can track it. But really the step beyond that, using the Internet of Things, this small Internet of Things device that can be more ubiquitous applied. What many people don't realize, but in the United States, when you go and sit down in the front seat of the car actually takes your weight. And it does this so it can vary the velocity of the airbags when they're deployed, if they're deployed. You would use a different velocity for a small child than you would a obese adult. And so even cars are beginning to do things like take measurements that could be useful in public health. But the Internet of Things is going to go much more dramatically. It can begin to help us look at nutrition, for example. It can begin to help us look at air conditions, smog, other things like that, pollens in the air and things that can help us in a public health standpoint to address this on a more global type of approach with it. You cannot talk about public health, but begin to talk about how do you prepare for and respond to pandemics, epidemics, all the other different types of things that we're facing here. And what we've seen with COVID is we have a long ways to go. If I present myself at a clinic with symptoms and they do not have access to my electronic healthcare records, it's a much harder road to provide me quality service. And so this whole reform around how do we get access to information, particularly on a global basis. I'm amazed. I looked at a statistic on a global basis of access to electronic healthcare records. And it's still not very good. Most of the world is still doing paper. And many prescriptions are written and faxed or hand carried to have the prescriptions filled, if they are filled at all. One of the other interesting statistics is in North America, over half of the prescriptions that are given to a patient are never picked up and filled. And if I begin to take and extrapolate this, particularly into developing nations, I think that trend will get even more severe going to a developing nation. It's one thing to be to get diagnosed. It's another thing to take the medicines. I have a feeling that many of us on the panel are guilty of taking a prescription, start feeling better, and quit taking it before we've gone through the whole course. And then many of us relapse a little bit. Again, in a developing nation view, I think that will become even more prevalent as we go forward. And I love the discussion on longevity, and Audrey is great. I love what he's doing. And when you go to the conferences on that, the panelists just blow me away as you begin to look at that. Outside of a serious wreck, I almost think if you're born today, the life expectancy is going to probably increase 50 years during a child's born today to there, because of our advances in genetics, because of our advances in being able to treat root causes to prevent disease and going there. And the ability to prevent disease, I think, is going to be one of the major policy issues in public health. How can you equitably apply these advances in particularly regenerative health and doing genetic alterations and things equally or across the population? The fact that we're seeing the increases potential to extend life expectancy is going to create a crisis in public health. It's going to create it from a delivery, a regulatory, a how do we pay for it? Because the costs to do those are extremely high today. And you're going to see that come to the forefront of what we're doing. And so if I look at the four major bullets I would put around healthcare, it's what is the acceptability? Many people understand they have a risk for illness and treatments, but the acceptability of those is still great. We saw that even with the things of wearing masks for COVID-19. The second bullet I put around it is accessibility. Are the medicines that can help me approved for my country, and can I get to them, and can I afford them? The availability is there too, and we're seeing that with, like I said, my discussion on rural medicine and affordability. The different models we have today just are in place to help us through where we're headed. COVID-19 has also dramatically brought to the forefront the political influences on public health. It has shown us that healthcare is not just a personal responsibility. Public health is not just a responsibility of between you and your doctors and other officials. It actually is a political involvement in your public health, a political involvement in your individual health, and how those elements play into the equation. So in many ways, we've talked in other podcasts like this about the public-private partnerships. Well, healthcare today, by de facto after COVID, is now public-private partnerships. Here in the United States, when I got my COVID vaccine shots, it didn't cost me a penny. And you're seeing that now. You're seeing government step up in delivering things where it breaks the model of how things were delivered in the past, and how that can work with you. The other one, though, is, and this one's a tough one, and particularly if I'm a developing country, is the ethical considerations around public health. The discussion on, do I need a COVID passport, brings up not only healthcare questions, public health questions, but ethical questions as well. And I think you're looking at that what in my world is the classic definition of not only complexity theory, but I think as we look globally today at public health, we're looking at really a picture of chaos theory. Because the decisions from each one affect each other and often overrule each other. You know, so the FDA makes approvals on medical devices and drugs, but the Consumer Protection Agency in the United States can override the FDA on some of the medical devices and other things like that. And then you go to Health Human Services, they have a voice in it too. You go to CDC, they have a voice. You got the federal legislative group making decisions that go around the others, and you have states and local regulatory groups doing it. And none of them are in sync, none of them really consult with the others. Now let me take that and extrapolate it again globally again. And like I said, in many ways, public health is a classic example of chaos theory and how the pieces come together. And one of the neat things about chaos theory, though, is as you get closer to the extremes on chaos theory, the solutions become simple. And that's part of what we need to do in public health, is take out of this complex systems of systems and find the things that we can simplify to make public health efficient and effective globally. And I really think with the technologies we're having, with the access to data we're having, as the ability to now extend communications, digital communications, into remote parts of the rural environment, we're going to see the ability for some of the first time to address this in a global manner, in a systematic manner, to be able to really make a dent in the future of public health. And you know, the other speakers have done so well going through the elements. I think that's probably where I'll end it right now. But it's possible for us in our lifetimes to make a dramatic leap in the accessibility and quality and capabilities of public health. So, Sharif, thank you so much for having me.
Thank you. Thank you, Professor David. Anyone has any question, or anyone want to add some point with Professor David Smith? Yes, Professor, Mr. David. Yes.
So I really liked your discussion about the difference between medical systems that pay for treatment on the one hand, which encourage treatment, often long ongoing treatment, versus value-based treatment, which prioritizes people remaining in health. And I wonder, is there a role for insurance systems, the payments of insurance, to prioritize people remaining healthy? That if they're taking actions that risk their health, their insurance goes up. Is that something that can lead to better value-based health, as opposed to this pernicious system which we have now, in which many people are prioritized to not actually cure people that well?
Well, I think there is room there. Again, in the United States, we're beginning to see that with some of the large insurance groups. One of the things here that is really interesting to me is over the last 5 years, we've seen large healthcare insurance groups buying medical practices. And you know, a great example is if you look at United Healthcare, if you look at the Blue Cross Blue Shield system and things, they've begun acquiring healthcare groups to help the healthcare groups do a better job of managing the patients who they provide the insurance to. Because it's actually in the insurance's best interest to have healthier patients and things. It's a slow process. There's, you know, it's not one that's going to change overnight, but it's kind of interesting looking at United Healthcare. Their medical practice side is now providing more to the bottom line than the insurance side. And you're seeing that through the way, and the quality health initiatives there are very large. And I think you're going to see that change a lot. You know, what we've been in some discussions actually with the folks in UK, and they're trying to change some of their models on this too. And I think that type of action will help, because if I'm a healthcare insurance company, I have more money I can keep in my reserves by not having catastrophic diseases that can be prevented. Now, you're never going to get away from I'm in a car accident or something like that. Those will continue to be fee-for-services. But I think our normal day-to-day healthcare will evolve quite a bit over the next decade to this quality healthcare group. And you're seeing that, you know, in California, you see Kaiser, as David pointed out. Kaiser has been both an insurance and a delivery since it was created. And it's a very interesting model how Kaiser even has evolved. And Kaiser was early in trying to bring physician's assistants, nurse practitioners into the mix to help balance the load. Because if you think, if I'm a doctor, there is a finite people I can see in a given day. And it's hard for a provider to have quality time with any patient because of the number they have to push through the door. So we have to expand our ability to use more of a collaborative approach to healthcare. And once again, a collaborative approach is what's going to be necessary for public health. So I think you see that.
Thanks.
Thank you. Thank you, Professor David Smith. Now I request Mr. David Wood for his presentation. You want to share anything?
Thank you so much, Sharif. This has been a great discussion. I'm going to try and have a slightly different approach. I'm going to look at the possibility for an emerging new public health paradigm. And I'm going to start by doing something that Rob Enderle said we should do. We should know what are the main causes of death, the main causes of ill health. And what's shown in here are the top 10 named causes of death, and the numbers are the deaths per year per 100,000 of the population. And this is actually from the year 1900. And if you're wondering, why am I looking backwards? Well, hold that thought. Basically, I think we can have better foresight if we have a clearer and more realistic understanding of what happened in the past. And I'm going to talk through a paradigm change in healthcare that took place in the past and use that as the basis to describe the ongoing new paradigm change in healthcare. So what are these top 10 named causes of death in 1900, you may wonder? What about cancer? Is that high up on that list? Not that high. What about dementia? Not that high. What about heart disease? It's quite significant, but it's not in the top 3 either. Stroke? Accidents? Well, actually, let me tell you what the top 3 causes of death in 1900 in USA, when I was still a sort of developing country. Number 3 was gastroenteritis. That's diseases of the digestive system, killing people by diarrhea. Number 2 was tuberculosis. And number 1 that year was deaths caused by pneumonia from influenza. What else is in that top 10? Kidney disease and diphtheria. And you'll notice there's a color scheme here. The ones in red, we now understand, though it wasn't clear at the time, we now understand are all caused by infections of one sort or another. Let me dig in a little bit here. Pneumonia was top that year, and influenza, because it was a minor worldwide flu pandemic, not as big as the ones that are more famous. But most years, in fact, tuberculosis was the largest killer. And in that year, 1900, 1 in 9 deaths were due to tuberculosis. Some people have estimated that tuberculosis killed at least 1 in 7 of all people who had ever lived up to 1800. It's been called the captain of death. And here's just a brief list from Wikipedia of some of the people whose lives were cut down in their prime by tuberculosis. And you might notice, as well as politicians and statesmen and royalty, there are many artists and composers and novelists in this list. Well, what were people's reactions to these diseases back in, say, 150 years ago? And many people said, well, there's nothing much we can do about it. Let's just be mature. Let's not be selfish. Let's just accept our fate with serenity. Perhaps we can pray, perhaps we can behave good, and maybe the gods will look kindly on us. Some other people said, let's regain our natural balances. Let's have clean, fresh air in sanatoria. Let's prioritize scrupulous hygiene. And there was something to be said for all of these 5 approaches, though still the death rates from tuberculosis remained frightfully high. What I'm going to talk about next is a radical, revolutionary, controversial idea that there could be targeted medical interventions against tuberculosis. And many people hated that idea. They said, no, 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 that's not what we should do. For example, this formidable lady, you probably don't recognize her. Her name is Mary Baker Eddy. She was the founder of what became known as the Christian Science Church. She wrote an influential book in 1875 and basically said medicine is dangerous. Medicine is a waste of time. Instead of trying to treat diseases like tuberculosis by medical interventions, we should pray for them. And she wasn't entirely wrong, because there's good evidence that medical interventions for most of history, until relatively recently, actually tended to damage people's health more than fix it. I met some members of Christian Science in my days as a student in Cambridge, England in the late 1970s. Bright people, clever people, well informed, but they also had that view. And even more recently, there are still sad cases of people who refused medical treatment for tuberculosis out of their religious conviction. And they said, well, we'll pray for them. And sadly, they died. Thankfully, there were other people who were able to make more progress with medical interventions. The person I'm showing here is the German physician Robert Koch, who was able to do things with microscopes that people had never done before. He had pioneering improvements in what he could see with his microscope, and he, in 1882, identified for the first time a particular microorganism that he could prove was the cause of tuberculosis. Rather than it running in families, it was something that was passed on from person to person. He also proved that different microscopic organisms were responsible for other ailments such as cholera and anthrax. And as a result of his intervention, eventually the treatment of tuberculosis improved and improved and improved. This is one of the remarkable graphs from the last 150 years. It shows the high numbers of deaths to start off with. People had a targeted hygiene improvements. They told people, shave your beards off, gentlemen, rather than spreading germs through kissing with their dirty beards. Women were advised not to have their skirts so long that they dragged along the ground. People were told not to spit. That helped. Then there were more targeted interventions such as vaccinations, which improved matters. Then from the 1940s, there were antibiotics. It turned out the first antibiotic didn't really help matters. It gave a temporary respite, and then the disease tended to come back more dangerous than before. But when 2 different antibiotics were used together, and even better when 3 antibiotics were used together, as from the 1950s, you can see the results there. Tuberculosis has been tamed remarkably. So let's just summarize. There was the interesting, radical, controversial idea that disease was often caused by microscopic organisms, and there was the fact that there were tangible interventions due to the progress of science, due to better microscopes, due to better powers of manipulating chemicals, due to better powers of intervening in biology. Things that I would describe as outputs of the second industrial revolution. It pushed down not only the deadliness of tuberculosis, critically, it pushed down the deadliness of gastroenteritis, the deadliness of diphtheria, the deadliness of all these infectious diseases. A single idea and a set of related new interventions could have a widespread impact. And if we now bring up to date, well, up to 2010, I'm looking here at data from a New England Journal of Medicine article from a few years ago, comparing the deaths in 1900 with the corresponding leading causes of death in 2010. And of these 4 that I've highlighted in red as being infectious, only 1 is still present in the top 10. That was pneumonia and influenza. If I fill in the rest, suicide, kidney disease, diabetes, dementia, actually killing fewer people, pro rata in 2010 than 1900. Accidents, again, killing fewer people. Stroke, again, killing fewer people. Chronic lung disease, a new entry. Cancer, killing a lot more people than before. On top of the list is heart disease, which again is killing more people than before. Now you can see there's a color scheme here too. And that's the basis for the forthcoming new paradigm change, which regards all of these, which I've shown in that brown color, as being chronic diseases, which likewise have a common cause. And that common cause is what happens with our bodies as we age. Here's a chart that Ilya Stambler already showed, and it points out that as we get older by various decades, the chances of us dying from these chronic diseases increases exponentially. This has been known since nearly 200 years due to the work of a pioneering insurance actuary, Benjamin Gompertz. So what? What are the possible responses to the diseases of aging today? And just as there were a variety of possible responses to tuberculosis 150 years ago, we see a variety of possible responses to aging today. And still many people say, there's nothing we can do about it. Let's just be accepting of it with serenity. Maybe we can pray, we can have good behavior, maybe we can regain natural balances, get some fresh air, and maybe there are some targeted individual treatments per each of these diseases. And all of that, again, has some merit. But here's the controversial, radical idea, which is that we can do medical interventions against aging itself. Well, it's one thing to have the idea, but you need the tools and the technologies to make it happen. And it's my view, this could not be done until relatively recently, just as the treatments for infectious diseases needed to wait for the technological enhancements of the second industrial revolution from 1870 onwards, thereabouts. Actually dealing with aging requires the technologies of the ongoing fourth industrial revolution, which is still in early days. AI-powered medicine, nanosurgery, stem cell treatments, which again have been mentioned by previous speakers, more generally by rejuvenation biotechnology. And if this seems a bit abstract, there are things we can learn from. There are some humans who live into their 90s and are as healthy as the average 60-year-old in terms of not being smitten by these infectious diseases. We can learn from not only human superagers, we can learn from animal superagers. These are animals, as Ilya mentioned, who don't age. They are in the minority, but there are certainly things we can learn from. And we can copy elements of these biologies into our biology, and even more interesting, we can apply new engineering methods which have never been done before. So just to summarize, the basic model is that as we live, our body is a hugely complex network of biochemical reactions, which does, as a side effect, create more damage as we live, damage at the cellular level. And as we are young, the body is wonderful at repairing most of this damage. but over time, the damage applies to these repair mechanisms as well, and they become less effective. And you can see that there is an exponentially growing character here to the amount of damage in our bodies. And the damage gives rise to these chronic diseases, which I've mentioned, including damage to our immune system, which makes us more vulnerable to infections. And when we're relatively young, the body can fight off these diseases, but as the damage grows, becomes increasingly severe, we succumb. For most of history, we have not managed to deal with age or aging or death. So the main philosophy has been to age with dignity, to cope with diseases, which is hard and difficult because as we age, we get more and more diseases simultaneously. Some people have imagined we could edit the metabolism of the human body so we no longer generate damage. And that is also very hard because the human metabolism is incredibly complicated, and most of the things that generate damage are also doing good things as well. And so this new paradigm is that we can actually intervene on a regular basis to undo the damage using mechanisms copied from nature and using these new techniques periodically, just as we currently go to the dental hygienic periodically to avoid getting gum disease and all the things that flow from gum disease. This is still hard, but it's less hard because there are a limited number of categories. Aubrey de Grey has 7 in his list. The Hallmarks of Aging paper has 9. I think Andrew Steele, the author I mentioned earlier in the chat, may have the best summary. He has 10 categories of aging and recommendations how we can deal with each of them. Well, I've rushed through that, and there are many other things to look at, some of which I cover in my 2016 book, The Abolition of Aging. And for the bigger issues and the many profound social questions arising, I point to my most recent book, which has just been available on the Kindle in the last week or so, Vital Foresight. How we can learn from history, how we can learn from the present day to foresee large changes in our healthcare system and many other things that are critical for human flourishing. So thanks so much for listening, and I now yield the floor back to Sharif. You're muted, Sharif.
Anyone has any comments or on Mr. David Wood?
Nicely done. I really appreciate it. Very nicely done.
Thank you. Thank you. So thank you, Mr. David Wood. I think now I want to request Mr. Donald for his remarks and presentation.
I want to first say it's been great listening to all the wonderful speakers. I always learn a lot and appreciate being on the show. I want to kind of make it a little bit different of an approach because my wife is a nurse practitioner and she works with underserved populations, which is basically a euphemism for poor people. And the particular group of people that she works with are generally migrant farm workers in California. And they're, and basically most of them are uninsured in the traditional way. In other words, they don't go out and buy insurance, or their employers don't give them insurance. They're insured through public program called Medicaid. I will say, I want to just mention what a nurse practitioner is. I mean, sometimes we use these terms. She, in her job, basically sees a lot of patients, sometimes like 20 a day. So the idea that the nurse practitioners have a whole bunch of time that they can deal with the patients is just not the case. I mean, they have a brutal schedule, and she does the whole thing that a general practitioner would generally do. So she meets with the patient, she evaluates what the issue that they're coming to see her, and she prescribes medication and the whole bit. And so she encounters things like tuberculosis because one of the sources of tuberculosis is usually people coming from countries where it's not, their healthcare systems are not as robust for like El Salvador or something, where there's a lot of drug gang wars and things like that. And it's difficult to kind of have a good top-down healthcare system, and it's also very poor. So the one, just right now, like yesterday or the last couple of days, she's been taking a class from University of California, San Francisco, UCSF, which is considered to be one of the best medical schools of all. And the class is in diabetes management. And what I know, listening to this class, I've been lucky enough to just listen to it. She puts it on, it's in the living room, so I listen to it. I've been listening to it, is that the whole thing about preventive care is central to the healthcare system. And I understand that there's drug companies and the incentives for drug companies to create drugs and to sell these drugs for very high prices, and that's an issue. But what they're talking about is this, is how to help prevent these problems. And of her clients, the biggest disease that she sees is diabetes. And diabetes, about 10% of the people in the United States have diabetes. Diabetes is a disease where your body can't metabolize the sugar that it gets. And there's two causes. One of them is an autoimmune disease that people get as children, which cause the pancreas, basically destroy the pancreas, which is the part of your body that creates the insulin, which is a hormone that allows you to absorb the sugar or utilize the sugar. And another one is that if we kind of don't take care of ourselves and we get fat and eat too much sugar and don't get enough exercise and all those kinds of things, our body loses its ability it loses its sensitivity to the insulin. So our body has to make more and more and more insulin to process the same amount of sugar, and that tends to wear out our pancreas. The second type is actually often repairable by changing your diet, losing weight, getting more exercise, eating less sugar, and generally taking better care of yourself. So that goes into the thing, is that if you're trying to do her job, the kind of job that what she's doing, very central to what her job is getting people to make lifestyle changes and to make changes in how they behave in their behavior, to be able to eat better, to get exercise and do the kinds of things that are necessary for them to be able to have better health. I mean, I, for years, went to a concierge doctor where I paid her directly because the insurance wouldn't take care of it for anti-aging, and I still take a handful of pills every day, and my cholesterol is like 110, and my A1C is, I mean, I've got all these things that I know really help prevent some of the things that cause aging. But somebody that can't read English, can't read at all, and the kind of people that she has that are coming to her, I think are probably more analogous to some of the issues in the developed world. So how can you work with people like that? And I think that one of the things that's key here is a matter of trust. And people do have a tendency to trust medical professionals. In fact, there's been studies that show if somebody reads that they're supposed to lose weight, they're less likely to actually lose weight than if their doctor tells them that they should lose weight. So there is trust in the medical profession. one of the things that really handicaps her is the whole issue of basically feedback. And that's an interesting place where technology comes into play. And just recently, she, just for, I don't know, learning purposes, wore a continuous glucose monitor. And what those are usually when people want to test their blood sugar to find out if their insulin sensitivity, if their insulin is working right, they prick their finger and they see how high their blood sugar is. And when there's a lot of extra sugar in your blood, it basically, it's almost like having little gravel going through your veins and arteries, and it tears up the inside of your veins and arteries, and especially the very small ones in the periphery in your eyes and things like that. It'll cause you to go blind and lose your limbs and things like that. And also destroy your heart and cause you to basically wear out and die very quickly. And so she wore this monitor so that you can test glucose on a continual basis. And that's something that they're trying to do now. It goes to what David was saying about IoT devices, but these things are not, they don't work very well yet. I mean, they're brand new, and even for one thing that's that simple, they've got a long way to go. So I think it's exciting, and it's something that we're really developing. But I kind of want to go back to something that Rob was saying. Rob has always been a big advocate of modeling, and he talked about the idea of social distancing and how if we'd done that earlier in the pandemic, it would have made a big difference. I highly recommend this book that's very engaging called The Premonition by Michael Lewis. It just came out. And he, he acts as a journalist, and he goes in and he actually interviewed and got to know all the people, some of the main people that were involved in dealing with the pandemic. And fascinatingly, they didn't know at the beginning of the pandemic that social distancing would work. They didn't even have an idea of it. In fact, they were sure that it wouldn't. They didn't even think to try it, because as far as they were concerned, it wouldn't work. One scientist studied, and that reason is because they found out, they believed that it didn't work during the Spanish flu. One scientist looked at a more micro, that was because they did it on an average. One scientist looked at it at a micro level and discovered that in St. Louis, where they actually did it, they had a much lower rate than in Philadelphia, where they didn't do it. And so he believed it would work. But a 14-year-old girl, for a science fair project, developed a social network analysis method of analyzing and her dad worked for Sandia Labs, so they evolved it into a real model. And that model basically proved that closing the schools, social distancing would work. It's unbelievable. So, I mean, where I'm going with that is to say that that doesn't cost anything. I mean, that was so cheap. There's our ability, but notice what happened with that. And this is where I'm going with this, is that the key to this is what wound up happening with that. People just didn't believe it because of the thing of trust. So to this day, there are people who don't believe it. If you look at the reason people aren't taking the vaccines, one of the large reasons that people aren't taking the vaccine is because they don't want to be guinea pigs. As far as they're concerned, they believe that vaccines in the past were much better tested than this vaccine, and because this vaccine wasn't well tested, they don't want to take it because they don't trust that it will work or not, or it might hurt them. So I think I'm going to say that it poses a dilemma, because if we talk about how awful the FDA is and how terrible it is that they hold up drugs and how rotten they are because they don't let drugs come out until they've been really tested and blah 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 like that, and all this anti-government stuff we hear all the time. At the same time, you have to realize that because we're not, what they do also builds the trust to be able to make these things wind up happening. So I don't know completely how it is that a country can build trust, but I do know that you can look at countries that do have trust, like a country like Finland, where I've lived, and I've actually partaken in their medical system, and I know how that works. They're not big enough to do drug development. They can't make new drugs. They're a teeny little country. It costs more money to make a drug than their GDP probably. And, but yet they have a very, very good comprehensive medical system. And all of these things are very complicated. And I think that the best thing that anyone can do is to look carefully. There are books about Finland's Nordic medical systems and things like that you might want to look into, because in the end, health is like the behavior that people have to become more healthy. It's an individual needs to do the things that make themselves more healthy. Most people don't have access to the information they need to be able to make the right choices. And the matter of trust, of being able to believe that you're being given information that allows you to make the choices that are going to make you more healthy, is key to any successful medical system. You're muted.
Yes. Anybody want to add some point?
Yes, thank you. And I appreciate that presentation from Mr. Steiny. Certainly a lot of the outcomes in a public healthcare system do rely on trust, and we see this in the United States with vaccine hesitancy. But I think there needs to be a lot more room given to individual agency and patient sovereignty, the ability of people to make their own healthcare decisions and to do so in a manner that is informed by the medical science. The frustration that I've had with the FDA in the United States is that it did not allow people who were enthusiastic about the prospect of receiving vaccines quite early on in the pandemic the opportunity to get them, even though the technical knowledge of how to develop the vaccine was there. The manufacturing capacity could have been ramped up very quickly. But for instance, people like myself who would have gladly taken a Moderna vaccine or a Pfizer vaccine in March of 2020 were denied that opportunity. And I think empirically the trust could have been built if the vaccinated cohort demonstrated significantly lower mortality rates at that time before the pandemic fatigue set in and a lot of people just became resigned to the inevitability of the pandemic and the kind of baseline death toll that had been observed since then. But if people in March, in April of 2020 saw that these parts of the population where people have predominantly decided to get vaccinated are experiencing very low mortality, whereas in these pockets of the population where people have chosen not to get vaccinated, the mortality is much higher. A lot of the people who would have had the hesitancy would have reconsidered. Now, unfortunately, a lot of these attitudes have become ossified because of politics. In part, the decision to get vaccinated or not has unfortunately become a kind of political tribal identifier, but also because so much time has passed that in some areas of the country, I think people have gotten so used to the pandemic being a fact of everyday life that they are now anchored in this as the new status quo. And I think status quo bias is an immense problem because, as David Wood mentioned, even something as perilous as tuberculosis, if it is present long enough in a population, could become accepted as just a baseline fact of life. So I think once these diseases emerge, they need to be combated as quickly as possible through the most effective suite of methods available. And when I think as to why the United States is among the countries that has now a better record in getting the pandemic under control despite many initial setbacks, and why also among the countries that have had this experience are Israel and the United Arab Emirates. And when I think of what unites these countries, I think it's a bias for action. It's the idea that in those countries' culture, the status quo is perceived as less acceptable than it is in the cultures of some other countries that may well have great healthcare systems, talented medical professionals, a lot of concern for public health. But what we see in Europe is predominantly a reactionary attitude. When the virus arrives, lock everything down indefinitely. But with regard to technologies that could end the pandemic, they follow the same skittish precautionary review process that could mean it may take years for European countries to rid themselves of this virus unless the United States ships massive doses of vaccines to Europe and essentially rescues the European countries. So I think having the bias for action, having a confidence that technological innovations can greatly improve upon the status quo, because the status quo is just that terrible, will be important to get us out of this crisis and out of future crises. We're still dealing with major public health problems. Diabetes is one of them, certainly cancer is another, Alzheimer's disease, dementia. We need solutions to all of these problems that don't presuppose that the status quo is fine or even tolerable.
Thank you. Thank you. Anyone want to add some point or as a concluding remarks? Mr. Donald.
I want to say one thing. I just checked it out. At the peak of the pandemic, there were 800 cases a day in Finland, and now they're down to something like 9. And so Finland actually, they trust each other. They trust their medical system. And so when the pandemic happened, they did what was necessary to do to abate it. In California, where I live now, the vaccination rates have gotten up to almost 80% and where I live. And so the pandemic is just fading away here because we're hitting herd immunity. But parts of the United States are at extremely low levels. And I think when we say something's political, we're not, I think we're kind of missing something. It's kind of like saying it's kind of too high level, because there could be a whole show and it's just an American problem about what's going on in the United States, but it does have to do with trust. There are people in this country who are, as he just said, are tribal. And I don't think that just doing it earlier or anything, there's just a huge amount of resentment against elites and things like that. And I'm not convinced that people are sophisticated enough to be able to look at statistics and things like that and make decisions in that way. I think that looking at the social issues of how these things work is almost more complicated than the technical issues. So anyway,
Thank you. Thank you. Thank you, everyone, for joining today's session. This is really, really important, specifically for healthcare policy. I think every country has a lot of challenges for healthcare policy and system development. Thank you, honorable speakers, those who support our initiative and join World Talent Economy Forum discussions. So this week, we have like other shows, but we will discuss on definitely on healthcare system. And most important thing is that we need more collaborations. We are open for collaboration, specifically developing nations. They need more support on modern science, modern engineering, and modern technology. Even though we have a democratic government system, but I think many places we have to improve and we need to develop better policy as well. So thank you, our honorable speakers, for support World Talent Economy Forum initiative. Thank you, Mr. Gennady, Mr. David Wood, Mr. Elias Thambers, Mr. David Smith, Mr. Robs, and Professor Donald. Thank you, everyone. Bye-bye and take care.
Thank you.
Bye. Thanks, Sharif.
Bye-bye.